All right, so we're going to talk just a little bit about mullerian defects, and this is in correlation with chapter 43. Now, if I can get it to go. So it's important for you guys to know a little bit about the congenital anomalies of the uterus and vagina. The uterus itself and the upper third of the vagina are derived from embryonic mullerian ducts. And these ducts must elongate, fuse, and form between the 7th and 12th weeks of embryonic development. So they develop in the first trimester around 2 months in. When something sequence fails to occur, one of the abnormalities results in its improper fusion, incomplete development of one side of the uterus and vagina, or incomplete vaginal canalization, which is the imperfect hymen. If a mullerian anomaly is encountered, kidneys should be examined for ipsilateral renal agenesis or morphological abnormalities, because these conditions are commonly associated with mullerian anomalies. And the reason is because the kidneys and the uterus and vagina develop at the same time. So let's say you are scanning a patient and you find that they have uterine agenesis. Their uterus has just failed to develop. Well, it would not be uncommon that one of the kidneys would potentially also not be there or not developed. So it's important when you do find one of these kind of mullerian anomalies to maybe take a look at the kidneys to see if something is up with them. This is a normal uterus. You can see this is the vagina here. This is the cervix, the internal os, the external os. This is the body of the uterus, this beautiful endometrial canal. And then you have two fallopian tubes connecting to the ovary. This is the ovarian ligament, keeping that a hold of the uterus there. And this is a normal uterus on like a 3D ultrasound. So this is showing you can kind of see the same thing. This is showing the uterine body and myometrium, and then this is showing a very nice endometrial canal. And that is how a normal uterus should look on ultrasound. Well, sometimes like these mullerian anomalies can occur and they don't exactly look like what we're used to seeing. And so it's important that you are familiar with these. So when you do encounter one of these, you're not shell-shocked and you know exactly what you're supposed to do. So yes, there is a thing such as a double uterus and double vagina. Two uteruses have developed. So this is a totally two different organs that are right next to each other. They have a vaginal canal, they have their own cervix, they have their own endometrial canal, and then they have a double one. This is the exact same thing. And these patients usually don't have any problems. I've seen this quite a few times. It kind of is confusing at first when you're doing a transvaginal ultrasound, but a lot of the times these patients do really good. The other really common one is a bicornuate uterus. It's called a heart-shaped uterus, and it kind of looks like a heart here. The difference between a didelphys uterus and a bicornuate uterus is, look at the bicornuate uterus. It has one vagina. There's two vaginas here. It has one cervix, two cervix, one body, two lower bodies of the uterus here, but then it separates into two horns, so they have their own horn. Now, the problem with this, with a bicornuate uterus, is that when a patient gets pregnant, when the embryo is implanted, it could potentially cause some issues because they're not having as much of a as much room as normal to be able to develop. So some patients with bicornuate uteruses actually have preterm labor with their babies. You can have bicornuate uterus and with a left horn that is not quite developed as much, but this is not as common. What I want you to know is this double uterus, which is the didelphys, uterine didelphys, the bicornuate, a septate uterus, which a septate uterus is a one that can really cause a lot of infertility because of there's a septum that is displacing the endometrial canal. So when an embryo tries to implant into the endometrium, it struggles to develop correctly because there's a septum that is causing issues and not enough blood supply, and a lot of these patients miscarry pretty early. So with a septate, the difference is between that and a bicornuate uterus is this is usually the septum goes down almost all the way to the cervix here. While the bicornuate uterus has more of a nicer endometrial canal. A unicornuate uterus is just one part, like one horn. And these patients, they kind of struggle also with pregnancy because they don't have as much of a endometrium as like a double vagina or just a normal one. Sometimes also they don't have the other fallopian tube to the ovary, so that can cause some infertility issues. An arcuate is also a congenital anomaly, and these are pretty common. I actually have an arcuate uterus too, so I am an abnormality, but I haven't had any issues with it. But it's just like a little dip in the endometrium. And these patients that do have these usually have no problem with infertility. They carry the babies till term, but it is considered a mullerian anomaly. So who knows? Maybe you guys have one. You'll have to check out yourselves and see. These are the classes of the mullerian defects, and just to be aware of these, you can actually have where there's hypoplasia or agenesis. So the uterus just doesn't develop. The unicornuate, there's different degrees of the unicornuate, but it's just basically a one horn of the uterus. The didelphys, which has two uteruses, the bicornuate, which has two horns, the septate, which has a septum going through the endometrium, and the arcuate. We also have what is called a DES, drug related, and it's a T-shaped uterus. So the vaginal atresia, that's class 1, and it's diagnosed usually by the development of hydrocolpos, hydrometrocolpos, or hematometrocolpos. And the vagina fails to really develop as much as it could, so there's a development of fluid because it's not able to escape. So when you see this, you're going to get this is a transabdominal ultrasound of the uterus, and you can see there's contents within the endometrial canal. It looks like blood, which is this hypoechoic, and some fluid. This is another example of a transverse ultrasound. So this is the endometrial canal that has filled with fluid and blood. You can also just have a uterus that has not developed. One of my patients way back when, actually she was like 16, 17, she had all of the symptoms of like, you know, going through puberty, but she had not had a period yet. So they wanted us to scan her, and I scanned her, and there is no uterus, but she had both of her ovaries because the ovaries developed from a different duct. Now the ovaries are what are responsible for our female characteristics. So of course she would still resemble like she was going through puberty and have all of the, you know, like development of breasts, just all of her female characteristics, yet she was not having the menstrual cycle. So it was kind of a sad situation because if you don't have a uterus, then well, you can't carry a baby. But because she has her ovaries, potentially there would be she could have a person to carry the baby for her, because she does have her DNA in the eggs, if that makes sense. So she does have her, and if potentially her mate or like husband wanted to have babies, they could, still do IVF, still have their own genetic baby, but just had a surrogate to carry. There was also a news article in Texas, I believe. They did a uterine transplant on a woman that potentially had uterine agenesis, and she was able to carry her own baby. So there are medical advances that are happening. So that's exciting for people that struggle or have these anomalies. Okay, anyway, class 2, unicornuate uterus. It's related to pregnancy loss and infertility just because there's only part of the uterus. And in sonography, you're going to demonstrate a long, slender, cigar-shaped uterus deviated to one side. So this is what it looks like. This is a unicornuate uterus. This is a normal uterus. And you can see on a 3D coronal scan that there's just part of the uterus kind of flipping to one side. This is an HSG, and you can see that it's a radiology exam that they can use, and they fill dye up through the vaginal canal and watch it, and you can see that there's only one horn of the uterus here, but then one fallopian tube. This is another example of it. A uterine didelphys, again, is the complete duplication of the uterus, cervix, and vagina, and it's not usually associated with fertility problems and usually doesn't require any treatment. Now, with the uterine didelphys, there are some stories of patients that have had multiple pregnancies, but are not at the same time because they have two uteruses, but are not necessarily twins because they don't come from the same chromosomes. They basically are just sharing a home. This is a dicavitary twin gestation at 12 weeks. They both have their own homes because they both have their own uteruses. So they're not like a monochorionic pregnancy that are sharing the same gestational sac. They're just, growing next to each other, basically. The funny thing is that I've always shared with our classes is there is a Grey's Anatomy episode, and you guys might have to look it up, where the mom was pregnant with twins, they said, but I think she had been with this man, but also another man at around the same time. So she was actually pregnant with two different men's babies. And I was like, this is the craziest episode. That cannot happen. But technically, because of how Grey's Anatomy works, they go to the depths of like a possibility. And technically, if a patient has two uteruses and she ovulates two eggs and she has time intercourse with two different people within a certain amount of time, she could technically have two different genetically from two different people's babies inside her. And that's what happened in this crazy episode. And I went back and I was like, oh my goodness, that actually could, once I started learning more about the GYN side of ultrasound, I was like, actually, that could actually happen. They weren't making that up. But it is kind of far-fetched for sure, because it would have to be just perfect timing. But she doesn't look like she just got caught. Mullerian anomaly, the bicornuate uterus, is the duplication of the uterus with the common cervix, and it's a bilobed uterine cavity, and it has wide space cavities, and it has low incidence of fertility complication, usually not treated, potentially preterm labor if the bicornuate uterus has a pretty deep kind of, not septum, but a deep cavity. But most of the time, these moms do pretty good. This is what a bicornuate uterus looks like. I thought that was a cute picture. But this, it doesn't usually have like a septum going down that far, but you have two horns. This is a coronal image of the uterus. Okay, so septate uterus, this is two uterine cavities that are seen closely spaced with one fundus, sometimes two cervical canals, or even a vaginal septum. So a septum just goes straight through the endometrium. Let me show you. So this, it's sometimes difficult to determine the difference between a bicornuate and a septemy uterus. But the difference is, see how this uterine body just has one uterine body? Well, this figure A has two horns. This is more of a bicornuate. It has its own horn. Well, this one only has one big fundus, but has a septum going through it. That's the difference. So look at this bicornuate uterus, and then look at this septum uterus. It's one body with a large septum going through. This C is more of like an arcuate uterus because there's not like a deep septum. And this is a larger septum, but just one body, while the bicornuate has two horns of the uterus fundus body. And then there's a drug that they used in the 60s called DES, and I believe it was for not to help prevent miscarriage in a patient that's pregnant. So a lot of these moms would take this drug DES, but they didn't know that this is actually causing the female that they were carrying to potentially have what is called a T-shaped uterus. So it was associated with an anomaly. So it was, of course, pulled off the market once they figured this out. And this is what it looks like. It's called like a DES exposure, and it's a straight T-shaped. When if you look at like a normal uterus, it usually spreads out instead of more like just straight with a T at the top of the fundus. Normal endometrium has a wider area. And so anyway, these with DES exposure, they struggle with infertility because the endometrium is not correct. So that's it for mullerian anomalies. Again, if you guys have any questions, just post on the discussion board. But I also want you guys to be familiar with these anomalies when you take your test in a couple weeks. All right, thanks guys. Have a good day.